All right. Hello, everyone. This is Nikki Anderson, the CVH Health System Supervisor and the Supervisor for the Minnesota Stroke Program. Hope you're all doing well today. Thank you for joining us for this month's webinar. And as we head into the end of the year, what we're going to do here today, I'm going to provide brief highlights from the state of Minnesota stroke care that were just covered at the Minnesota Stroke Conference. We thought it would be valuable for everybody to have the opportunity to hear this information, and thus decided to share it here today on a webinar. Some of you, the first part of today's webinar certainly will be a repeat of the information. However, it does give you the opportunity to perhaps catch something that you didn't hear the first time. And I'm also delighted to be joined today by our evaluations specialist, Mimi Amalang, who will share results of both the annual hospital and EMS inventory surveys. So this is new stuff, and you'll surely want to stay tuned in for that part. All right. So before we get started, in typical fashion, we like to go over some housekeeping items. This webinar is part of the MDH Stroke Program Education Series and is being recorded. Stay tuned to your email for a different educational opportunity, typically each month. And you can access previously recorded webinars on our MDH YouTube playlist. Your lines are muted, so they've been muted upon entry. And please ask your questions by typing them in the chat or holding them for a closing Q&A if there's time. And again, as always, if we don't get to your questions here today, we will follow up in our follow-up email. This webinar also has a 0.5 contact hour associated with it, so you'll receive that upon completing the corresponding evaluation. We'll put that link in the chat at the end, and it will also be on the closing slide, which I'm not sure if you'll be able to click on that link in the deck or not. All right, so today's agenda, again, it's the 2023 Minnesota Stroke Program and stroke care highlights, in addition to results from the 2023 EMS and hospital inventory survey highlights. Objectives for today are to understand current stroke hospitalization and death rates in Minnesota, summarize current performance for the stroke-specific measures that are the statewide quality reporting and measurement system, or the SQUIRMS measures that we collect, and then describe results from the 2023 hospital and EMS inventory surveys. All right, so let's dive into the state of stroke care in Minnesota. Figured this picture was a little fitting considering we're heading right into winter and ice fishing and frozen lake season is upon us. So we did have the pleasure of announcing this year's Quality Improvement Award winners at the Minnesota Stroke Conference. You're going to get to hear more from these colleagues directly in our January webinar. And just a friendly reminder here today that this is our last live webinar of 2023. So we'll see you again in the new year. Congratulations to these folks that are listed here on the slide that work at these different organizations. And one more thank you is, we wanted to thank those of you who were at the Minnesota Stroke Conference and bearing with us as we worked through the process and handing out these awards. I definitely think we learned a little bit, and we'll certainly do better next year. But it was really fun to recognize the amazing work of your colleagues in person and to hand out those awards. So tune in January. So it's been 10 years since Minnesota statute was written into law. And what an incredible journey this has been. This is our newest map that showcases 94% of Minnesotans now living within 30 minutes of a designated stroke system hospital. And that means we've witnessed an increase in 1.9 million additional Minnesotans now having better access to stroke care. So as designation expanded from the beginning, so did our data collection efforts and participation in the Minnesota Stroke Registry, because that is required of designation. So what did a typical stroke patient look like back in 2015 when we really had a good amount of data collected? Well, the mean age was 71.4. Typical race, 4.6% of patients were Black or African American, 1% were American Indian or Alaskan Native, 2.4% were Asian, and 76% were white. Medical history, the typical medical history was comprised of 44.8% of patients having a history of hypertension, 30% had a history of dyslipidemia, 18% had a history of AFib, diabetes at 17.2, and stroke at 14.6. So fast forward to 2022, the most complete year of data that we have. That information is here on the left, and there's some bolded categories in there. We also pulled over information from the previous slide so you can see them in comparison. So we've certainly seen some changes in the landscape of what a stroke patient looks like now as compared to back then. The diversity of our population is changing, and so are our stroke patients. More patients have a medical history of hypertension, diabetes, and stroke, and all the more reason why we've been tasked by the CDC to focus our efforts on stroke prevention, knowing that hypertension and high cholesterol increase stroke risk. This map on the left, this depicts the stroke and TIA hospitalization rates by county from 2018 to 2021. Excuse me. And the dark areas represent higher rates of hospitalization. The map on the right is the social vulnerability index mapping of Minnesota. The darker areas on the map on the left nearly match up with those on the right. Social vulnerability index is the social, economic, and demographic factors that affect the resilience of communities. So things like poverty, lack of access to transportation, and housing are examples of things that fold into those types of results. So our EPI team combined the social vulnerability index and stroke and TIA hospitalization rates, discharge data together. And we were able to identify that the most vulnerable communities have the highest rates compared to everyone else. So remember how those maps nearly matched up on the previous slide? Specifically, people living in metropolitan areas like the Twin Cities, Duluth, Rochester, St. Cloud, Mankato, Fargo, and Grand Forks have higher rates of stroke hospitalizations than others. We showcased a similar slide last year that looked pretty similar to this, but we added another year of data, so 2021 is included. And we also added the 25 to 34 age bracket because we have seen a trend in strokes happening in younger populations. And, you know, as you can see here, and another reason we're hoping many of you consider looking at your data with an equity lens is that some communities are burdened with stroke events so much earlier in life than others. This data comes from the hospital discharge data set, and we know we need more data that's accessible and available to you. Over the next year, we will be working on updating the Minnesota Stroke Portal to expand upon our current data collection fields. We understand that some of you may not be collecting data within your organizations that get to such a granular level, and that's okay. This is our first step as a stroke program to change how we collect data, specific to the rapidly growing diversity of our state, that will someday help us identify ways that we can address unique patient needs and hopefully eliminate inequities. So now we can dive a little deeper into stroke treatment and the acute treatment of stroke. So from the hospital inventory survey, Mimi's going to dive deeper into that later, but this is one slide from that. And this shows that majority of the state is using tenecteplase as their primary agent for the treatment of acute ischemic stroke. We continue to do really well treating acute ischemic stroke patients with IV thrombolytics, and this remains steady and has remained steady over time. This slide here gives a better visual of the total amount of ischemic strokes with the number of patients treated with IV thrombolytics. You can see that we've seen an increase in ischemic strokes steadily over time, and treatment has remained steady as well. Perhaps we do need to make a push more towards awareness and getting patients to the hospital sooner. And I thought this slide was really cool and was excited to share this at the Minnesota Stroke Conference and equally excited to share this here today with all of you. We took a look at the overall lytic treatment and broke it down by designation level. So you can see increase in treatment over time in acute stroke ready hospitals. And it's not concerning that there's a downward trend from the comprehensive stroke centers because we're recognizing that treatment is happening. It's happening at the local acute stroke readies. And that was the goal of the system and remains the goal of the system. As well, you can see a brief dip in 2020 across the board. And you're going to see that in a lot of these slides that are presented. But things certainly feel or appear to be returning to normal now as we head into this, continue to work through this post-pandemic state. Thrombectomy treatment, that's remained steadily, or that has steadily increased over the years and remains again at a stable level. And this slide here are the number of patients that received thrombectomy, but were transferred to the higher level of care for treatment. So they arrived first at either an acute stroke ready, primary stroke center, or even a comprehensive stroke center in certain situations that may have needed to be transferred to another site. The number of patients being identified as a large vessel occlusion at the transfer site that then received thrombectomy treatment has steadily increased since 2015. From our data, roughly 40% of thrombectomy patients are actually transferred from another hospital. Quality improvement is a core component of a successful stroke program for all of you individually and for us as a state and as the Minnesota Department of Health. You're all doing so much to improve care delivery to your community. And we'll talk a little bit about that here with the SQUIRMS data. So for you guys know, this has been around for many years. These reports are available within the Minnesota Stroke Portal. And the door-to imaging metric remains stable, with 72% of stroke patients receiving imaging within 25 minutes of arrival. Now, just a reminder, these SQUIRMS measures are available online for the full listing of the inclusion and exclusion criteria, but there are specifics to it. So not all the data is included in this because of that inclusion and exclusionary criteria. And this is something that made us perk up a little bit when looking at the data, because the door-to-needle SQUIRMS metric has increased in 2022 to 80.8% of patients receiving treatment within 60 minutes of arrival. Does this directly correlate to the shift in tenecteplase? That's certainly something to consider, knowing that drug administration has been simplified. We'll continue to keep a pulse on this over time, but for now, I just kudos to all of you in improving treatment times for this subset of acute ischemic stroke patients. So what are we doing and where do we go from here? Well, at MDH, the Minnesota Department of Health Stroke Program, we do aim to work across the care continuum. And many of our efforts have expanded into community settings with prevention at the forefront. One project that was unexpected and graciously funded by a grant through our own division at MDH was the Health Equity Innovative Grant. We were inspired by our partners at Hennepin Health, who created a video series for stroke prevention in Somali. The presentation is still available on our YouTube playlist, so check that out if it's something you haven't seen before. It was a really neat project, and we were really proud of these partners and appreciated them sharing this with you as well. So what we did here, we partnered with Hispanic Outreach of Goodhue County to create Spanish videos and Kaleidoscope to create simple culturally informed video messages for cardiovascular disease prevention. And these videos were done in Spanish and Hmong. The best part of the project, though, was that this was done with community members, led by community members, and done in locations that of their choice and in their preference. We do have the Hispanic videos online. I sent those out with last month's message. We'll be sending those links again along with complimentary written materials that coincide with what the videos review. So stay tuned. We'll get that online and get that out to you guys here soon. And the Hmong videos are coming soon. We don't have that entire series completed, but what we do have completed, we want to get online and available as soon as possible. And our public awareness toolkit, that's something that's been around since 2019. It's available on the web. We, as a team, worked on enhancing promotion of this resource available. They're free and available for download, something that you can take for your own organization and brand it as well as MDH branded or branded to your own healthcare organization. And in that promotion, requests have come from all over Minnesota, which was really exciting to see, as well as North Dakota, Iowa, Ohio, Oklahoma, and India. So seeing the reach of the Minnesota stroke system across the nation and even across the world was pretty cool to see over this past year. So what's next for us? In the next year, we plan to support the American Heart Association's efforts to update statute to include thrombectomy capable stroke centers. We'd love to secure more funding for our program and for the state and plan to submit a budget proposal in the coming years. We'll also be reapplying for federal funds through the CDC in early 2024. So stay tuned. We're definitely going to need help. We're going to need support, and we'll certainly be reaching out to you guys for that. I did have the stroke team stand up at the Minnesota Stroke Conference, and I think they were none too pleased with me doing that. Um, I'm not going to have them all pop on camera here today, but here they are listed online. In addition, I'm really excited. We have a new colleague who has joined our team. Her name is Jamie Carlson. We'll be sending out information and welcoming her in this next month's message. She is a planner and comes to us with a great experience working with community, and we'll be working on some initiatives across cardiovascular health in our unit here at MDH. All right, I think that's the gist of my content here, and I'd like to hand things over to my colleague Mimi, and just bear with me as I pass her the presenter role so she can take over from here. Okay.
Great. Thanks, Nikki. Hi, everyone. Thank you for joining us. I am excited to share some of the highlights from our hospital and EMS inventory surveys this year. I'm going to start out with our response rates. And first, I want to say thank you so much to everyone who responded to these surveys this year and responds every year. We get response rates back to these that are really unheard of in the world of surveys. So on the EMS side, we surveyed 262 agencies. We heard back from 114. That's a 43% response rate, which again is considered very high when you're doing large surveys like this. For our hospitals, we surveyed 126 stroke programs and heard back from 113 for a 90% response rate, which is just out of this world. So thank you again, everyone who responded, for sharing your insights. This does really help us get a sense of what's happening on the ground in stroke care and stroke protocols, and it does support our reporting back to our national funder, as Nikki mentioned, which is important for us to be able to continue to do the work that we do. So I'm going to start with hospital QI. We always ask a chunk of questions about your QI initiatives in the last year. And this year we see that programs completed a broad range of projects, initiatives looking at key stroke metrics, documentation in the medical record, and stroke code activation were the most common. But we can see a whole host of other topics being addressed in the rest of the graph here. Our EMS partners are also working on stroke PI or QI. About a quarter of agencies did a QI or PI project related to stroke in the last year. Those looked at most commonly recognition of stroke-like symptoms, reduction of on-scene time, hospital pre-notification procedures, and then again, there is a nice list of additional areas of work. So hats off to our EMS partners for that work. So you may have heard from us in the last year or so a new kind of focus on dysphagia screening. So we wanted to know how many hospitals worked on a dysphagia screening project in the last year, and it was about half of you. And then in the remaining half who hadn't worked on it in the last year, half of those said that it's something they plan to do in the coming year. So you will definitely be hearing more from us on supporting those initiatives. Few hospitals currently have pediatric stroke protocols in place. So this is another topic that's kind of bubbled up over the last year. Certainly having a pediatric stroke protocol in place is not a requirement, so we weren't surprised to see that low number on the yeses there, but we do see a lot of interest in working on this. So over half of our respondents were interested in potentially developing a protocol for pediatric stroke. So again, stay tuned for more on that. When it comes to health equity initiatives, about a quarter of our stroke programs worked on health equity in the last year. In most cases, that looked like participating in hospital or health system-wide diversity, equity, and inclusion or other similar initiatives. Often looked like stroke awareness campaigns targeted to specific communities or patient groups. And then many programs were working on translating materials into different languages. and starting to track data for specific patient populations and or improve interpretation services. So only a small number of hospitals are currently looking at stroke data by patient demographics. This is something that Nikki mentioned that we are also interested in supporting. And again, we see healthy interest in this at 36%. We know that there are barriers to looking at data by patient demographics. Staff time is the leading barrier, unsurprisingly, but so are competing priorities for data analysis. And I think this is a common issue in a world where increasingly we have lots and lots of data, but we don't always have the time or the staff power to analyze that data. Now we know our hospitals are screening and referring stroke patients to help meet their social determinant of health needs, such as housing or food insecurity. So about a quarter are using a SDOH screening tool with stroke patients. Note that just under half are unsure whether there's a tool like this in place. So that yes percentage might actually be quite a bit higher. Almost 70% are referring stroke patients to community services or resources to help meet their social determinant of health needs. And a little over a third are using community health workers, community paramedics, or other patient navigators to support or follow up with stroke patients. Over half of stroke programs are conducting some kind of public awareness activities, which is great. In all cases, those hospitals have some kind of posters, pamphlets, or videos that are being shared in the hospital, but they're also going beyond the hospital walls. So posting on social media is fairly common, about 70%, as well as tabling or participating in community events or offering presentations or education sessions in the community. So this is really cool to see, and we think definitely reflects you guys going above and beyond what's required to reduce the incidence of stroke and improve outcomes. Now, again, we acknowledge that there are barriers. Far and away, the biggest barrier to doing public awareness is staff time. We know many of our stroke coordinators are wearing many hats and are stretched quite thin. And so those percentages on the previous slide, I think, are even more impressive given these barriers. We also see that cost is a barrier, unsurprisingly. We did see in the survey that there's a need or a desire for translated public awareness materials. So over a third of hospitals said they would need translated materials for public awareness or patient education. The three most commonly requested languages were Spanish, Somali, and Hmong. And so I want to jump out of survey results quickly to kind of go back to something that Nikki talked about, our Every Second Counts public awareness toolkit, which is available on our website. And Michelle, if you could throw that link into the chat here, that would be awesome. I wanted to highlight that these materials are now available in Hmong, Spanish, and Somali, in addition to English. And so that image on the right is from our, I believe that's our Hmong social media graphic. And then we'll also have additional info sheets on stroke and cardiovascular risk factors in those same three languages available online soon. So if you visited us at the stroke conference, you may have seen or taken home a copy of those materials in hard copy. They'll be online for you to print and continue to access soon. So popping back into our survey data, looking now at EMS partnership, most hospitals are providing feedback to EMS partners. That typically looks like providing individual case reports, presenting at stroke committee meetings, or having informal summaries or discussions with EMS staff. So a small minority are providing some kind of aggregated reporting on EMS patients to their EMS partners. We asked our EMS agencies, or I'm sorry, we asked you guys, our hospitals, whether EMS participates in your stroke committees, and nearly 70% said yes. However, when we asked kind of the same question to our EMS partners, only about a third said that they were invited to participate on their hospital partners stroke committee, and over 20% were unsure. So I can't speak to where that disconnect might be coming from, but I wanted to highlight this because when we further asked those who said yes, they were invited to participate, whether they were participating, 90% were. So it's pretty clear that if our EMS agencies are invited to participate on the stroke committee, they will say yes and they will participate. Most EMS agencies are using stroke severity assessment tools. So this is another topic that we've been looking at and working on over the past year or so. Most that are using these types of tools are using the FAST ED. And then in terms of EMS use of our MDH resources and participation in our activities, we see that the leading resource being used is our recent stroke severity tool best practice document. So that dovetails nicely with that previous slide, and we're glad to see that this resource is being used. In addition, they're frequently using our EMS and or public awareness toolkits. Finally, when it comes to hospitals participating in MDH activities, nearly 80% are participating in this monthly education series that we're in right now. That's awesome. We are so glad to have your participation every month. A little over a quarter sitting on our QI collaborative, 20% participating or using our MDH Learning Center courses. A little reminder that those are a great long-standing resource for longer stroke education and training than our 30-minute monthly series. And then 20% are on our stroke advisory committee, which is our PSC and CSC hospitals. So that is my last slide as far as survey results go. I'm going to turn it back to Nikki, and I think we are both happy to take questions. Nikki, let me get this over to you.
You got it. Thanks, Mimi. Thanks, everybody. Thanks again for joining us. We do have a few minutes here for questions, if there are any. Please go ahead, drop those in the chat. Feel free to unmute. And I know that one of my team members as well was going to put the evaluation survey link into the chat as well. So make sure to complete that to claim your credit for joining us today. And I'll stop talking to see if there's room for questions. Okay, so I see that there was a question about the link that doesn't work for our Every Second Counts campaign. That is something that we can also send in the follow-up email too, to make sure that that gets to you all correctly and is working. So I apologize if it's not working from the chat here.
Nikki, I'll post another link to the request form for the toolkits, and maybe that one will work. Another tip, WebEx does weird things with links sometimes. So if it's not working for you, you might want to try just selecting and copying and pasting that link. You might have more success.
Awesome. Thanks for that pro tip, Mimi. All right, let's see. Tess has a question in the chat. Let me get that pulled up here. Sorry, I'm having trouble navigating that on my screen. Just a moment.
Hi, Nikki. I can
You got it, Michelle. Thank
share
you.
this question. Thanks, Tess. The question is, besides program participants, where else is this data shared? With the legislature, and yes, also with CDC. That is accurate.
You got it, Tess. That's a great question, and thanks for joining us here today. We do share that information with CDC. Some of this is part of our reporting that we are required to do, as well as other things that we like to share, because Minnesota is certainly a national leader in the care that we deliver and some of the things that we do. There are plans to share and update information with the legislature in the future. We've been working as a team here on creating a report that should hopefully be available for not only us to share, but for you all to share as well with folks that you talk to or your certifying bodies, specifically those that are certified by like the Joint Commission or DNV. So those are things that we are working on and hoping to do in the near future, is share this more broadly.
A follow-up, what can each of us do to inform our local legislators now?
That is a great question again. I would say, let me think on that and let us think on that. Because we certainly, as mentioned, we're gonna hopefully be submitting a budget proposal in the not this year, in the next session. So we'll certainly be seeking support, but being proactive versus reactive is certainly something that we want to consider. And now or sooner versus later is certainly a smart approach. So we'll follow up with some more information there.
I don't see any other questions. I know there's a little bit of concern still for that Every Second Counts toolkit. And if you do copy and paste that link into a different browser, it definitely should work for you. But we will also include it in our follow-up email to make sure you get it and get access to those great resources.
All right. Thanks, Michelle. And thank you again, everybody, for joining. As I mentioned earlier, today is our last live webinar of 2023. We look forward to seeing you in January. I hope you all have a safe and happy holiday season. You'll still hear from us. There's some year-end wrap-up things that we would like to share, but don't stay tuned for that webinar invite next month. You'll see us in January. Take care, everyone.